Thank you all for being here and welcome to Echo Dementia on this September 23rd, a beautiful fall day. I'm Amy Pattison. I'm facilitating today. Our two co-leaders have other commitments today. And so I'm here to welcome you and facilitate. We will go through some opening notes and reminders, and I think we're going to go ahead and skip introductions. All the names look very familiar. If indeed you are here for the first time and you speak up, which we encourage, make a comment or ask a question, please introduce yourself. And in a few minutes, I will invite Christina to present our didactic on fall prevention for people with dementia. So just some Zoom reminders. Please enter the names of all the attendees from your site into the chat. Please mute your microphone when you're not speaking and say your name when you unmute. And we appreciate having your video on if indeed it's working. We like to see you and we like you to see us. Just some reminders, protect private health information during these sessions. Please do not display or say anything that could reveal a patient or family member's identity. Don't forget, we are recording all these sessions and they're available on our website. And please take the time to complete the 1-minute post-session survey. Our upcoming didactics are listed here, and that list is available on our website. As we enter into the fall and then the holiday season, please note that in November and December, we'll be hosting just one session. And in November, that'll be on the 3rd Friday of the month. So if you have some ideas about an upcoming case presentation, your cases are a vital part of our community learning. We appreciate that. We actually don't have a case today. We're going to have some discussion after the presentation, but feel free to reach out to Allison if you have a case that you'd like to share with us. A reminder, there is an accreditation for CME credit through the University of Washington School of Medicine. Today's speaker has no financial relationships with any ineligible company relevant to the presentation, nor do any of the planners have any relevant financial relationships. There is contact hour available through the School of Nursing. So here we are, our community, as we're spread across the state of Washington. It's exciting to have so many sites participate in these sessions. And again, put your name and role and clinic name in the chat if there's a group of you. Here is your hub team available for working with this presentation. And with that, I will invite Christina Cosley from the Harborview Medical Center Falls Clinic to present our didactic this afternoon, Fall Prevention for People with Dementia. So Christina, I am going to stop my share and turn it over to you. So welcome and thank you for being here.
Thank you. I am going to get this all set up here. Thanks for having me. I'm Christina Cosley. I'm a physical therapist and I've been a PT for 21 years, 14 of those years at Harborview and the last 4.5, I've spent my time focusing on geriatrics for folks who are at high fall risk. So I really enjoy my work at Harborview. I spend a couple days a week in the Falls Clinic seeing patients with Dr. Phelan and Dr. Rohrbach. And then I follow up on all the fall prevention treatment in our clinic in the 9th and Jefferson building. So thank you for having me. I've been asked today to talk about fall prevention for people with dementia. And some of the topics that we'll cover today, I'd like to review some of the unique fall risk factors for patients with dementia, talk about some unique screening and assessment tools that you can use in the clinic if you're wondering if your patients are at risk for falls. We'll touch a little bit on the benefits of physical therapy for fall prevention, specifically for people with dementia. We'll talk about the really important role of the caregiver and a brief overview of some treatment techniques that we can use in rehab. And then, of course, when to refer your patients for therapy. As we know, over 55 million people in the world are living with dementia, and this is expected to grow to approximately 139 million by 2050. We know these folks are 8 to 10 times more likely to have a fall and less likely to recover from that fall. I've got a list here of some of the unique fall risk factors that you'll see in your patients with dementia. So their type of dementia, their neuropsychiatric symptoms, a more sedentary behavior, unmet needs, and caregiver burden. Below, there's a list of more pronounced fall risk factors in these folks, but they are similar to ones that you would find in your general geriatric population for folks who are at high risk for falls. When we're talking about screening for fall risk assessment in this population, there's a few tools that you can use to make it easy and quick. The first one is the CDC's STEADY Stay Independent Questionnaire. This is in your supplemental materials, and I'll show a screenshot of it as well and talk you through it. Ideally, you're going to ask the caregiver or that really close family member to fill that out. The other thing you can do is get a really detailed history from the caregiver on their daily routine, their general physical status, how much activity they get, their functional mobility status. You know, do they need assistance getting in and out of bed or on and off the toilet? And then you'll go into your falls focused exam if that time allows during your visit. The cardiac eval, assessing for orthostatic hypotension, your medication review, asking about when their most recent eye exam was, because our folks with dementia aren't necessarily going to report a change in vision. And you'd also want to get an idea of their gait and strength and balance. This can be hard to give somebody a bunch of verbal cues and ask them to do a physical task. And so if that's the case, you can also demonstrate the task that you're going to ask them to do. Maybe you want to see them go from sitting to standing out of a chair and see if they can do it without using their arms. Or maybe you want to see them walk down the hall. Another really good fall risk screen is their gait speed. I'm going to show you a chart on that as well. So this is the copy of the STEADY Stay Independent Questionnaire. Again, you're probably having that close family member or caregiver fill it out. And there's a list of questions with yes, no answers. So for each yes, there's a point number associated with it. At the end, you tally up those points. If they get a 4 or more, then they're at risk for falls. And you can start intervention. This is a chart on gait speed that I got from a class that I took from a PT named Kay Wing. And I write gait speed goals all the time for my patients. I'm generally writing them for about 1 to 1.2 meters per second. So that's what these values are. They're in meters per second. And if you look at that, kind of the right side, so 1 meter per second and above, you're going to see these folks more likely to be independent with daily activities, less likely for hospitalization, more likely to be able to be living at home, and also much more likely to be a community ambulator. I like to use this chart also for motivation purposes, because sometimes patients' goals are to be able to go to their grandkids' sporting game or be able to go out for lunch with their family members and get out and do some things and be a active community member. Below the 1 meter per second, you can see patients more likely to be dependent in daily activities, more likely to be hospitalized, and need intervention for fall risk. They're also going to be more likely just walking inside their house. It's not as likely that they're going to be really functionally getting out in the community or crossing a street in time. So this is a great tool to use. And I even think if you could mark off 10 meters in your hallway as your MAs are potentially rooming your patients and have them just time how long it takes your patient to walk those 10 meters, calculate the gait speed, and it's going to give you some really useful information. So in terms of physical therapy intervention for patients with dementia, as we're working on falls, we know there's really good evidence, especially for mild to moderate dementia, that we're going to do a multimodal program. It's going to include strength, balance, endurance, and Tai Chi as much as possible. We're going to make sure patients are trying to get 2 to 3 days a week of exercise. It doesn't always have to be in the clinic. Maybe they're coming to see us once and they're doing a couple days a week with their caregiver. The goal is that they do it for about 6 months, and that gives them that goal of 50 hours of balance practice, which sounds like a lot, so that they can really make a difference in their fall risk. And we know that this type of exercise can slow the rate of their functional mobility loss, especially if we can start seeing them earlier on in their stages of cognitive impairment. We want this exercise and PT to be very individualized. So because of that, I don't have, handouts to provide it. We have to really meet the person where they're at and work up from there. We want it to be really enjoyable for them, and we have to involve their caregivers. So the caregivers are super important. I think they are the reason why we are successful in our medical treatment, our physical therapy treatment, our rehab treatment. Caregivers help the patient on a daily basis get physical activity, help maybe stick to somewhat of a daily routine, some regular sleep. They can make sure that their sensory aids are available, like their hearing aids and glasses, especially if they're going to be up and mobilizing. They can monitor for pain control needs, elimination needs, and just help reorient them. So when we involve caregivers, we have to engage with the caregiver and our patients with dementia. We really want to see what their needs are, specifically what their preferences are, and really try to offer some choices and options. We know that if we do this, that we'll have a much higher level of adoption of our fall prevention strategies. The caregivers will really have to be part of the exercise program, mostly because we want the exercises to be performed safely, correctly, and consistently. So I will often have caregivers like behind the patient and I doing the exercises as well and learning them so that they can be a really good coach at home. And at times we might keep patients in therapy a little bit longer so that we can achieve these goals because their learning needs are different. And we also might suggest a group exercise class. So some of these folks really benefit from watching someone consistently demonstrate the movement or the activity. So a class is a nice way for them to get that consistent ability to follow along and continue practicing the exercises. That being said, I thought I would just touch really quickly on some caregiver resources. We know caregiver burden can be a part of this, and our Alzheimer's Association has some really good resources. I enjoyed poking around on the website and learning a little bit. So if you just go to alz.org under this help and support tab, there's several topics here. And if you click on caregiving, it comes up with another menu of topics. And one of them that I thought was nice was, for the caregivers to learn a little bit about stages and behavior. There's some topics on here on like how to best communicate and interact with our patients. And I also like that there's a section on caregiver health so that they know that their health and well-being is also an important part of this. I'm going to talk a little bit next about some therapy treatment techniques. So these are just other things that we can integrate into PT or OT. The first one we've already talked a little bit about, and that was basic exercise. So again, we're going to be working on strength, balance, endurance, trying to incorporate Tai Chi when we can. There's really good evidence that that is even better than standard balance exercises for fall prevention. Cognitive training is another piece that we can work on. This is often done in OT, working on executive function, alternating attention. But in physical therapy, we can incorporate some cognitive training, or we might call it dual task training, where we're having the patient do a physical task, but we're asking them to also perform a cognitive task. So maybe that's skip counting or listing things or counting, forward or backwards. So that helps them have a bit of a brain exercise and a physical exercise at the same time. And we'll continue to include functional training. So making sure we continue to preserve the ability to perform basic functional tasks like transfers and sitting to standing so that they can always have the ability to get up from any surface, out of bed, off the commode, out of the dining chair or sofa chair. And when we can, call on more procedural memory that's preserved. So for basic tasks like sit to stand or going up and down the stairs, we can do that for functional training. Errorless learning is something that I really learned about as I was doing some research for this presentation. And it's used when that traditional trial and error method isn't really going to be successful. And the way this works is that a task is set up to reduce any kind of errors or guessing. So it's really, really specific, broken down into small pieces. And those small pieces are practiced really consistently with consistent cueing until the learner's mastered it. And then those cues are gradually taken away and they become more independent with that physical task. The other piece of this that I think is really important, and some of it's just been on the job learning for me, is using a lot of positive emotion, a lot of rewards, a lot of encouragement, maybe even bringing in some relaxing music. I mean, we really want exercise for them to be enjoyable. Maybe it's sensory assistance. And for me, what I have done in some cases is if I have a patient with dementia, I'm probably not going to always bring them into the gym where there's mirrors everywhere. There's a ton of equipment. There's people coming and going. There's multiple conversations. All that stuff can reduce their ability to focus on the task that we're doing. So I might take them into a treatment room where it's quiet, there's less stimulation, and we can focus more one-on-one. Less distractions. Again, just trying to optimize their ability to put attention on the tasks that you're doing, but also stay motivated. Assistive devices, this was another requested topic for this, and it's a really, really good question. I think we all know the benefit of assistive devices. They help support the body when the legs are weak. They can offload a painful joint like a hip or a knee or an ankle. And they can give the patient a wider base of support, and that's always better for balance. But the thing is that they really have to be able to use the device safely. So if you're giving a person a device without adequate training or in a stage of their dementia or a phase of their dementia where it's not really appropriate, it could lead to more falls. It could be unsafe. So my experience with this has been, for folks with more mild dementia, I can at times get people to learn how to use a new device safely, or maybe someone who has more moderate or severe dementia, depending on if they have 24-hour caregiver assist or someone that's always present, to bring them the device, to remind them to use it, to remind them how to use it correctly. And those are situations where it's usually pretty successful. And anything in between is really just very individualized. And that's where I think in PT, we really have the benefit of working with people, multiple sessions over months of time, and really trying things and having that ongoing assessment and really tapping into the caregiver or the family member and asking them what they think, and what they think might be possible at home too. And obviously with treatment, having a practitioner that has some experience with dementia, with the types and stages of dementia, how to apply some alternative learning strategies, because those standard ones may not be as successful, and how to really involve caregivers. For your medical treatment techniques, you're going to, continue working towards things that you would with your general fall risk population that's listed here. One of the things I feel like we all have a really great opportunity for is also addressing home safety. There are some specific resources for home safety for folks with dementia. And this is also in your supplemental materials. I found this great handout from the Alzheimer's Society of Manitoba. And this is just the first page, so you can know which one I'm talking about. But following this is a really specific list of home safety techniques specific to patients with dementia. And so in my mind, I'm thinking, when you see your patients and you've done your medical assessment, maybe you're going to refer them for some rehab. Wouldn't it be great if you could also send them home with a really specific home safety checklist, more specific than just the general population? And this is obviously from Manitoba, so you might want to take a look at it and make it your own and tailor it for your clinic. But what I thought I would do is go through some of the home safety techniques and highlight the ones that really seemed unique for folks with dementia. So the first one is adequate lighting. Again, this is pretty obvious, but think about additional resources like a glow in the dark light switch. You know, maybe it's not dark enough for those night lights to come on, but someone needs more lighting, and a glow in the dark light switch would be easy to see. Motion censored lights, I also thought were a great idea, especially at exterior doors. So if a loved one heads outside and you're not sure that they went, you don't know that they've gone, the light comes on, so they've got adequate light, but maybe it also alerts you that they've left the house. Visual contrast, this was, you know, probably by far one of the most interesting ones for me, where safety, things that they're going to use for safety become really obvious to see, and it's really helpful to differentiate the background from the foreground. So if contrasting colors are used, say for bath mats or handrails, you know, like a handrail that just blends into the wall may not be seen. And if that's what they need to use to get down the hallway and get to the bathroom safely, we want to make sure they see it and can use it. Non-slip tape at the edge of a step that's a very different color than the stair. All of this helps with providing visual contrast and helping with depth perception. Keeping pathways clear, again, sounds really obvious, but going, you know, kind of getting to the nitty-gritty of it, keeping furniture in a really simple arrangement, minimizing clutter that can kind of take their attention off things that they're doing, keeping furniture in a really consistent location. There are a lot of times where folks say, well, I went to sit down, you know, in the chair and it wasn't quite where I thought it was going to be. You know, keeping everything really consistent, really simple, plenty of room through the walkways. Enhancing accessibility to really frequently used items. So items that they're going to need frequently or want frequently, keep them in a consistent location and also in a really easy to reach place. We don't want them doing anything dangerous to grab something that they need. Also, labeling cupboards or drawers with the names of contents may also help. Bathroom safety, the one that stood out to me here was lowering the water heater temperature for safety. Footwear, that's generally what we would recommend for any patient at high risk of falls. No socks or barefoot walking inside. You want them in shoes or slippers that cover the toe and heel that have a non-skid sole. And then just reducing noise level, reducing extra stimulation, sudden loud noises, anything that could distract them at a time where, let's say they're, you know, sitting up from the couch and trying to focus on using their walker safely. You don't want some loud sudden noise to distract them and possibly have them lose their balance. In terms of referral to physical therapy, ASAP, as soon as you find some of these things we've been talking about. Obviously, the earlier we can get to them before their cognitive impairment may progress, the more successful they will be at reducing their risk for falls. And also think about early referral for patients who have Parkinson's disease, vascular dementia, or Lewy body dementia. We know that those gait and balance impairments are going to be more prominent. And really pay attention to changes in gait, whether it's something you observe or the family member reports. We know that those changes in gait can be a really early biomarker of dementia, that those changes happen before you know, we're objectifying some of the cognitive changes. And then in addition, just even a fall alone in your older patients can also be a good opportunity to assess for cognitive changes. I put this slide in here just to be complete, that at some point there may be a need to transition to a more palliative approach. As the dementia progresses, as you get to those possibly later stages in Alzheimer's, if the patient's already dealing with, you know, an aggressive chronic disease, and they're getting to that point, Then focusing mostly on educating the caregiver that falls are a part of the progression of dementia, but certainly continuing to address functional needs and safety, as well as comfort and well-being. Those are ways to just transition, and that maybe the goal isn't practicing 30 minutes of exercise a day, but just keeping them safe with their day-to-day functional movements. I have a couple slides of references that you can feel free to look through. I looked through a lot of stuff for this talk. This is what made the cut. And then I wanted to say thank you so much. It's really a pleasure to be able to present, and especially during National Fall Prevention Awareness Week this week. So thank you. And I'd love to take your questions or work through some cases with you.
Christina, thank you so much. My gosh, that was a wealth of information and so many great resources. Really appreciate that. You know, I'll go ahead and start with a question. You talked about referrals as soon as possible. Can you do kind of a routine referral, or do you have to wait till the person has had a fall, or what? Can you just maybe expand a little bit on the criteria?
Yeah, I can speak mostly to what we do at Harborview, because I think that any physical therapy clinic would be a little bit different. You know, for us, falls and fall risk is a pretty high priority because, you know, these folks, especially our seniors, they don't have a lot of time, and we do need to intervene as quickly as possible. So for us, they're pretty high priority. And mostly when our staff gets the referrals, they send them to me and I say, okay, you know, have them come. I can usually get them in much sooner than our general population. So I really try to prioritize that. And we do work in teams with physical therapist assistants, and we have some wonderful PTAs that know our Tai Chi program and this whole fall prevention program. And that actually helps me be able to care for a lot more patients.
Okay, thank you. So you answered one other question I had about the types of dementia that put people at higher risk for falls, when you mentioned with Lewy body or vascular people, yeah, with Parkinson's. Anything else to say about that?
Not necessarily. And I obviously, I think it's probably pretty obvious that, you know, the later, you know, more moderate to severe dementia, it's going to be higher fall risk, most likely. And then in the ones where we know there are, you know, motor characteristics of their disease process.
Mm-hmm. Okay, thank you. Would open it up for comments or questions for Christina.
This is Franja. Allison's got a question too.
You go first.
Okay. Christina, thank you. That was a lot of really good information. One of the things that I'm wondering, just from your personal experience, in my setting, we tend to see patients when they're kind of beyond that window where you're trying to catch them and keep them functional. And any strategies about people who are restless and wanting to get up often and walk, but aren't really safe to do that alone anymore? Any tricks of the trade?
That's a really good question. I might have to defer to our inpatient folks to help answer that. I know at Harborview, they use a really specific screening tool to screen for risk in the inpatient setting. And then given that tool, they then, you know, determine which kind of level of intervention they're going to do. I am not as familiar as an outpatient therapist in that, but I think the inpatient folks would be the ones to help answer that.
Okay, sounds good.
I'll ask my question. Christina, thank you so much. That really was some amazing information. I'm from the family caregiver perspective. Nighttime, you know, I remember caring for my dad, and no matter what we tried to put into place, you know, a pad that would make a noise when he gets up, or asking him to ring a bell, me sleeping by his feet in a sleeping bag, like he was wily, man. He would just get up and he'd be halfway to the bathroom before I'd be aware that he was on his way, and then bang. So I'm just wondering if there's anything else that you can think of. I mean, eventually what we wound up doing is bringing in somebody who had to be awake all night long when I couldn't do that anymore. And so anything else I'm missing?
No, I mean, I have to say, I think at the phase that we're seeing our patients in Falls Clinic and an outpatient, we don't have this come up a lot, but I think that you probably already answered your question. It's like, because you can't give them things like sleeping medicine to help their sleep, because that's even more unsafe and will increase their fall risk. And so, yeah, if once family gets to a point where it's just not practical for them to be doing it, then having someone come in, or, maybe those are times when folks and families start considering memory care. But yeah, because I don't know of another way to do it for safety.
Yeah.
Yeah, it's hard.
Thank you.
Yeah.
Lynn has a question in the chat. Lynn, do you just want to ask your question?
Sure, I can just ask. I'm just wondering what you're seeing in terms of people being referred, people that are living with dementia, and maybe comment on the various stages about being under referred to PT. And I just ask this because working in the settings we work with in, I think, sort of residential settings, I think a lot of providers, they think there's no potential for PT to make progress. So I'm just sort of curious what you think about, the kind of referrals that come in for PT, and could it be better utilized?
I think you're absolutely right. I think that most of the time when I get patients with dementia, it is through the Falls Clinic. So maybe they're already an established senior care patient and they're at high fall risk and they have dementia. And, we know as a team that they can still make benefits. But I would say, other than those referrals, I don't normally get patients referred with dementia. And, as we talked about, even mild to moderate dementia, we can make some changes. And I say everyone deserves a chance. That's just my philosophy. And so if you have a really willing caregiver, or maybe there's a caregiver and a family member and they're taking turns and they're both really willing to work with us and learn it and help the patient at home, I'm all in. I say everyone should be giving it a try.
Thanks. Yeah, I bring it up because we had worked with the UW to adapt the enhanced fitness program within adult day services, and Full Life Care in Seattle still does that program. It started out called Enhanced Mobility and then became Exercise for Mobility. So the point was getting people to exercise enough that they could actually make some gains, but also be safe in the process. And through like that adult day program, we actually did see some real progress for people. And the fact that they could get up and walk and continue the sort of being able to get up and down from a chair, families saw a big difference. And that, it was like a 20-minute exercise program. But it integrated a walking program, like an expectation you'd walk a certain amount of distance, like several days a week, not strenuous, but walking more than just moseying, like consciously walking around. And there was just a difference in both mood and functional ability over time. So, I think if you get people into those like programs where they're doing that, or like you say, working with a family member who may want to walk themselves, but gain the confidence to do that, I think it can make a big difference. And I just think people don't see the potential for a person with dementia to actually gain strength or perhaps, balance training. So
absolutely. I agree. And I have loved learning about those adult day health programs and enhanced fitness and knowing that exercise is a part of it. So I love the results that you saw. That's awesome. I agree with you.
Thanks.
Thanks, Lynn.
This is Franja one more time. And the reason why is because what Christina, you and Lynn are talking about is a little bit, it's making me have a shift. And the reason why is hearing that this PT in the outpatient setting is beneficial for patients who already have this cognitive information is kind of like mind-blowing to me, because oftentimes I think about when we discharge patients from the hospital acute care to an inpatient setting, the feedback that we get from families is that they actually continue to decline in their functional status, like they're walking even less. And I'm just wondering, about if that is kind of the idea. Okay, a patient may not be a great fit for an inpatient rehab setting, but that doesn't mean they're not going to benefit from, some very intentional efforts to get a little bit of that walking back, that mobility back in an outpatient setting. So thank you for talking about it. And I guess if you have a patient who you think is not a good fit for skill time, can you still try to figure out a way to, because there's like, no, this patient's not a good fit and they don't qualify for PT, but then it sounds like they would really benefit from PT in the outpatient setting. What do you think?
Yeah. Your first thought about inpatient rehab, I mean, I agree. Inpatient rehab's pretty intense. I think it's still like 3 hours of therapy a day. And I think it can be a lot for someone. And so, certainly there are many options, even if outpatient PT doesn't become one of those options. Programs like we were just talking about, like adult day programs, where adult day health, where there is structured exercise that's led by, I think it's led by an OT, if I'm correct, an exercise professional. This can be really helpful. Or even other community service, community center, or senior center. They'll offer exercise classes. And if you can find the right fit, we'll often work with families and patients to try to identify a good fit one. That idea of them being able to just follow somebody, and watch somebody move, and then they can move and they can do it as long as they're watching someone else. And then they can continue to exercise regularly. There's definitely options. And I say keep referring them to outpatient PT because they all deserve a chance. And again, they can learn and they can make improvements.
I just wanted to add to that. I think that the environment of inpatient rehab contributes to a lot of things, including delirium and other compounding factors that are probably negating some of the benefit that might be seen otherwise for therapy. Whereas in the outpatient setting, again, it's less intense. There's less stimulus. It's less confusing of an environment in general. So that just sort of came to my mind.
That's a really, really good point. I think one of the articles I reviewed was about hospital delirium and falls. So yes, good point.
Do you ever have
there were a couple of other people with hands up, but now I'm not seeing them. Barbara, you have.
Yeah, do you ever get people referred to you who are in a wheelchair for physical therapy? And did you see it brighten their mood and improve some factor? Did you talk about that a minute?
Yeah, absolutely. I mean, I'll even see patients who primarily use, let's say, like a power chair to get out in the community. But if you think about it, it's not really how they're getting around in their home. So they still need to maybe be able to use a walker to walk short distances. They still need to be able to transfer in and out of bed. Right. And then, I have patients sometimes come in wheelchairs that maybe they're propelling themselves or their family members propelling. And that a lot of it is just so that they're not super pooped by the time they come to therapy. So we talk a lot about, kind of situational uses of different assistive devices. And I'm always kind of plugging that assistive devices are tools, so that they can help you do more and stay more independent. And absolutely, I get to see people's moods enhanced a lot. And maybe for folks who have more progressive dementia, I get to see their family members or their caregivers get really excited and proud. So yeah, it's really awesome. But yeah, I take anybody. It doesn't matter if they have a wheelchair or power chair or what device they're using.
Okay, thanks.
Yeah.
Thank you. Cynthia, you've had your hand up. You're a patient.
Yes, I am wondering, I'm working with a resident who is moderate dementia and always complaining that she's too weak. And when I, am able to get her to using her walker, she is always saying she's too weak. And I've asked her to identify if she has any pain. And she says no, but it seems to be a constant thing. And I'm wondering if you have any good tools or advice on how to maybe evaluate someone's pain level. This person has had 2 hip replacements and a knee replacement.
Okay.
So I'm just wondering, would rather hold my hand and walk than use her walker, and I strongly discourage that.
Okay.
So I just, yeah.
Yeah, I mean, if there's, in the absence of someone being able to really tell you if they have pain, you could look for physical signs of pain, especially if you think it's in their leg. When they're walking, I think one of the telltale signs is if they're putting, like asymmetrical weight bearing time. If there's a leg that they just want to scoot off of as soon as they step on that foot and they want to be off of it, that might be indicative of some pain anywhere in their leg. Or maybe just watching for grimacing as they're transferring, like going from sitting to standing can be a difficult task on like the hips and the knees. And so if there's grimacing or they, really slow down, those might be physical signs of pain. But I think it's great that you continue to encourage the walker because that is, more independent. And if you determine that maybe it's not so much pain, but they really just don't feel strong enough, like what he or she is saying is they feel weak. There are exercise videos that will have, they're really general, put on by the National Institute of Aging. And it's just seated upper body exercises, and then some sit to standing, and then standing, holding support and doing leg exercises. And if done, with a caregiver for safety, it might be a way to help build up some strength and make them feel more confident with standing and walking.
All right, thank you.
Great.
Yeah, you're welcome.
Great. Marielle.
Hi, this is Marielle. Thank you again for that presentation. It was super
welcome.
informative because I actually go into patients' homes. And so this was good for me to have a better understanding when I do present physical therapy, especially with patients with dementia. I had two questions.
Okay.
One was initially about, I often find that providers will prescribe devices like wheelchairs, walkers, Hoyer lifts, all these things, but then I don't necessarily see any training for those devices. Would that be an appropriate time to put in a referral if I just, am noticing, they have like a bunch of different devices, but we're still not doing a great job of being independent or promoting ambulation or safety because we're having falls, things like that?
Absolutely. I think that, safety device training is super important, and I love doing it. And so, yes, absolutely. Good reason for a referral.
Okay. And then the other one is you had mentioned about training, like group instruction for caregivers, because I often find patients will be discharged from PT and then I'm talking to the caregiver and they're like, I only saw the therapist once. And I'm like, oh, well, that wasn't very helpful for you getting instruction. So how do I get them that resource so that way they can be more secure in their assistance?
Yeah, that's great. I have caregivers always join the sessions. They can join as many as they want, but the more they join, the more helpful it is. And I'm often like checking in with both the patient and the caregiver to make sure everybody feels like we're on the same page, whether that's with like the written instructions I give for home or the type of instruction I give for home. Is it going to be on paper, or am I going to try to share one of those videos? But I think that just the more they can be involved during the therapy sessions, like I said, yesterday I had a woman doing Tai Chi behind us, so I can see she's really teaching herself so she can teach her mother at home. So yeah, I think the more time they spend in the therapy sessions, the better.
So if they missed opportunities and the patient could continue to benefit, would it be worth putting in another referral?
Absolutely. Yes.
Okay.
For review with caregiver, for home program success. Yes, absolutely.
Okay, perfect. Thank you.
Yeah.
Okay, any other questions or comments? If not, I have another one. Christina, you mentioned some videos, and all the time you're talking about these people coming into therapy, I think, oh my gosh, how do their families get them there? Particularly for an extended period of time. But are there good videos that you would recommend or encourage families to use at home?
Yeah, there's one. It's put out by the National Institute of Aging, and it's a really basic upper and lower body strength, endurance if you do the whole thing from start to finish, and then a little bit of balance work. So it definitely wouldn't replace therapy, but it's just a nice something at home, especially to just be doing strengthening. It's a public domain of information. So Harborview at one point was making copies of DVDs, but nobody has a DVD player anymore. So, so I do have a link. If it's okay, maybe I could email Allison. I don't have it pulled up right now, but we found someone who recorded the video and then put it on YouTube. And it's just been something kind of tried and true that we've used, because again, it's a way for general strength, endurance, a little bit of balance. Someone can follow if they've got their caregiver there too for safety. It'd be a great way to do those exercises. And I always find it's easier to follow someone else than be like rifling through papers and trying to figure out what to do.
Christine, if you wouldn't mind sharing that, that would be great.
Yeah.
We always, in the invitation to the upcoming session, we also have we share resources from the previous session. So if you can get that to me, I'll post it there. Thank you.
Great idea. Yes, I will do that.
Okay, Owen, you have a question.
Yes, I was wondering, I have a lot of patients with assisted devices, and compliance is sometimes a big issue. Now, my technique is basically just tell them, hey, it's important to prevent falls, and then next thing you know, they're back in the hospital with a hip fracture. Are there any techniques that you can give that can increase the compliance for these assisted devices?
Yeah, I mean, I think if you're at a point where like rationalizing, then there's that part. Like it's a tool to help you stay independent. We know that you want to keep your independence, and we know that you want to, continue living at home. If you're kind of beyond that, then it may be like, I've wanted to take like really bright tape and put it around people's walkers. Just again, like we talked about contrast and visual contrast. Like if it was really standing out, would it be a little bit easier to remember to use it? And then beyond that, like that's just where the caregiver, I think, or the family member comes in really handy to always make sure it's right next to them, because they're going to switch locations. And if they forget to take it, always make sure it's next to them, remind them to use it, and maybe even remind them how to use it safely. We have had instances where people have more than one device. If there's multiple levels of a home, they've got a walker for upstairs and a walker for downstairs, or canes. They've got canes, one in the car, one by the door, one upstairs, one by their bedroom. Those are just a few suggestions that I could think of off the top of my mind, but in a lot of instances, I do think it comes down to a caregiver or family member really making sure they're using it consistently and safely.
Okay, any other questions or comments from our audience?
I have a question I'm going to direct this towards Carolyn. I'm just wondering if there's any kind of tech solutions that would encourage use of devices. Like I think about, I know people who hardly walked at all until they got a Fitbit and it started tracking how much walking they did. I don't know, if there's something on the walker that like, your walker went a mile today, and I don't know, some sort of incentivizers, like you can have a cookie awesome. if you go a mile. I don't know.
I don't actually know if this is a great thing for me to look into. I actually don't know if there's like walker Fitbits, but it's a clever idea. I mean, if the person was wearing just the Fitbit on them and they went with the walker, I mean, that's one option. But yeah, most of the things are more in that like prompting or kind of, pinging in, saying like, oh, you haven't moved much in the past hour, and what I like about some of those things, and whether it's, your Apple Watch or something else, is that they can, you can change whatever that setting is. So it's not something astronomical, right? You're not asking somebody with, moderate to late stage dementia to run 3 miles a day. But you can modify those goals and then the timing of when it might ping you as well. So it wouldn't be as persistent. It can be a little more gentle, perhaps. But it's an interesting idea, though, something that would actually be attached to a device. I'll have to take a look at that.
Thank you. Both Karen and Lynn have put additional resources in the chat. Karen, about your local area agency on aging is a great place. And also Lynn put a link in the chat on safety checklist for persons with dementia. And those resources are in the chat. So thank you for that. So Christine, I'd like to pivot a little bit if I have your permission. And I would like to talk about now the persons with dementia who have fallen and have a serious injury and now become a hospice patient. And those patients are extremely difficult to take care of, often involves pain management and all of that. And ultimately, they often die within days or weeks once they become bedbound and need additional medications and kind of the spiral of events. We do all of the death certificates for, well, really all of our hospice patients, so thousands of them a year. And when there is ever an injury that we think is contributing to death, we have to call the medical examiner or the coroner in the 3 counties that we serve. And I think depending on how busy they are, how short-staffed and other variables, they decide or decide not to take the case. And we cannot declare a death as an accident. Only the medical examiner can. And it just seems like, and my colleagues can speak up who helped me completing these death certificates, we're calling the medical examiner more and more all the time. And sometimes they'll say, oh, just take it off the death certificate. And sometimes they'll say, we will take the case. And then I think I worry about those deaths being labeled accidental as opposed to from dementia, because we know what a resource death certificates are for both research, resources and funding and all of that. And I just wonder if anybody has any other thoughts about that or experiences. I think it's probably something we should have a discussion with our county medical examiners or coroners about, to make sure that all of these cases really are recorded appropriately. I mean, I think there needs to be a category with dementia, with fall and serious injury or something like that. Yeah, there isn't. So Brock, you're shaking your head.
Yeah, I agree completely. That's a really good idea.
I agree completely too. That hadn't even entered my mind, but I think that that's very important.
Mm-hmm. Our mortality epidemiologists in the Department of Health do such an excellent job in this state in making sure that the dementia deaths are appropriately attributed to dementia. And I know I have actually done some work with them. It's been a while. And Lynn, I don't know if you have any comments about this, but I've always thought it was one reason why dementia is a more common cause of death in this state than in other states. And it's because of how we record it.
Mm-hmm.
Yeah. Lynn, you're muted.
Yeah, we had delved into that when we did the first Alzheimer plan, because we did have a higher rate and we didn't know if it was reporting or actuality. And, it could be a bit of both, we don't really know. But they at the Department of Health, they tend to, they do dig and they go to a few diagnoses down. And so I do appreciate that. But I think it does make us look higher when you compare us to other states. So I think other states should be doing what we're doing, because I think it's better.
Oh, I agree.
So, but you're right, Mimi. There probably aren't enough categories. Fortunately, they're doing the work to try to figure that out. If you're dying with dementia or from dementia, there's sort of this distinction out there that people have talking about.
Mm-hmm.
So I don't know what the wording would be, but I agree it would be good to capture.
Mm-hmm.
Capture
Who wants
it.
to take that on? as a project. Any volunteers in the audience? You all think it's important. Anyway, okay. So are there any other comments or questions? What great discussion. Wow, thank you. Allison, are we going to let these people out early on this beautiful fall Friday?
We could certainly do that. I suspect that there are people who could find a way to fill their time.
I bet. Oh my gosh. 18 minutes.
Woohoo.
I'm going
just
to,
gonna share my screen again
that would be great.
and remind us that the next session is Friday, October 15th, and the didactic presentation will be visual impairment and dementia. That should be excellent. Dr. Bonnie Keung, a neuro-ophthalmologist from Swedish. So we'll look forward to that. And Christina, thank you again for your presentation and all the wonderful resources and wonderful dialogue that we had regarding this topic that is so important.
Thank you so much for having me. I really enjoyed this. And I just want to say thanks to everyone out there in the audience for listening, but also for the great work that you do. And I really appreciate this. And, please feel free to reach out to me if you have any other questions.
Thank you.
Thank you.
Okay, with that, I will say thank you all for your attention and have a great rest of your day and weekend.
Yeah, and I popped a survey into the chat, but I also emailed it to everybody, so you should have that.
Please complete that. We really appreciate that.
Thanks, everybody.
Okay, thank you.